Hello, this is Dr. Robert Frantz, the director of the Pulmonary Hypertension Clinic at the Mayo Clinic in Rochester, Minnesota, and professor of medicine in the Department of Cardiovascular Diseases at the Mayo Clinic. I'm here today with Dr. James Klinger, professor of pulmonary and critical care medicine at Brown University and director of the Pulmonary Hypertension Center at Rhode Island Hospital. Jim, great to have you here today.
Thanks, Bob. Good to be here.
We're going to spend a little time talking today about longitudinal care in pulmonary arterial hypertension. And this really involves this concept of having instituted a treatment plan, gotten to know our patients, and think that we understand their situation at a given point in time, but recognizing the uncertainty of the world of pulmonary arterial hypertension, we have to have a plan for how we're going to follow these patients. When are we going to see them back? How do we assess the tolerability of their therapy? And how do we assess the efficacy? So when you're first meeting a patient with pulmonary arterial hypertension and get to know them and come up with a treatment strategy and implement that, how do you finish that interaction with regard to when you're going to see this patient back and what are you going to do when you see them?
Yeah, so I think these are always good points of discussion at the initial visit or at least the first follow-up visit, and particularly when you're starting therapy. So kind of like any other disease, I think most patients are expecting that there's going to be some type of monitoring going on to see how they respond to therapy. And it depends quite a bit on how ill they are. We're familiar with this functional class stratification that we like to use to get a rough idea of how severe patients are. And that's the class where we divide people into group 1, 2, 3, and 4, with 1 being asymptomatic and 4 being extremely symptomatic. When you have patients who are in the 4 group, the most advanced disease, we think follow-up is extremely important, and we usually see people on a monthly basis until we're convinced that they're responding positively to therapy. When you get people down in that class 1 and class 2 range, now they start to complain about how necessary is it that we get regular follow-up. And so those people will frequently follow anywhere from 3 to 6 months. And this has been the general recommendation of the professional societies and the World Health Organization, is that people with pulmonary hypertension be followed about every 3 months. But as you get closer to that 3B category and that functional class 4, we like to bump that up to every 1 to 2 months. And then, of course, as you get better, we stretch it out to every 6 months. I think there's general agreement that we should see patients at least twice a year. And the reason for that is because you can change quite a bit a year. And sometimes, it's not always evident. Unlike systemic blood pressure, where you can get your blood pressure checked in your doctor's office or even at the drugstore, there's no easy way to actually measure your pulmonary arterial pressure and your cardiac output to determine if it's getting better or it's getting worse. And so now we really rely an awful lot on the patient's symptoms. And the problem with this is that active people tend to notice changes in symptoms early, but inactive people tend not to. So for some of my patients who are running on a regular basis or have an exercise protocol that they follow, even small advances in disease they pick up fairly quickly and are likely to call the office and say, I got to get in and see you. But other people who are simply going from the couch to the kitchen and back again may not notice any change in symptoms over a fairly long period of time, even though their disease is progressing. So to keep all that under surveillance, we usually suggest a general follow-up about every 3 months. And then, like I say, sicker people we see more often, and better people who are doing well we see less frequently.
So for that sicker patient who was sort of in that class 4 category, and they're going to come back in a month, what are you going to do at that month visit, and what will you have done even in the weeks after you first see them in terms of telephone contact and so forth?
Yeah, so I generally tell people that aside from the right heart catheterization, there are 4 or 5 ways that we can tell by kind of surrogate markers whether or not patients are responding favorably or not. And the first one is how they feel. That is to say, is it easier for them to do things? Are they getting around without less fatigue and with less shortness of breath? Or has the treatment not affected their lives at all? And of course, there's always a bit of a placebo effect there. We have many times when patients will say they think they're getting a little bit better, even though their spouse or their family members don't agree with them. And then the second thing that we like to look at is the walking distance itself. And this can be very good in people who are normally mobile and not so good in people that have trouble with hip pain and joint pain and whatnot. And we can't do it every office visit, but it's a relatively simple test, and we do it quite frequently. And again, if they're maintaining that walk distance or extending it, and particularly if they're doing it with less dyspnea and with less drop in their oxygen saturation, then we start to feel that they're getting better. And then, of course, the more significant diagnostic tests are things like measuring the brain natriuretic peptide level or measuring the actual right ventricular performance on echocardiogram. So between those four things, the functional class, the walking distance, the BNP, and the echocardiogram, we get a pretty good idea of what's going on. And then what I'll tell people is that when all four of those parameters move in the same direction, we tend to believe them. And when they all move in different directions, then we get confused. And when we're confused, we have to talk about repeating right heart catheterization to see where we're at.
The nurses also play a big role, don't they, in terms of that telephone contact and, for example, titrating prostanoids. And so often our nurses will be touching bases with the patient on a at least weekly basis in the few weeks after initiating parenteral prostanoids to go over side effects and discuss additional titration under our protocols and with the discussion with the physician or nurse practitioner. So this really works pretty well in terms of very tight telephone follow-up, which keeps them in close contact with our center, and I know that most centers would be doing that as well. When we talk about tolerability, what are the highlights there in terms of what we're asking our patients when they come back about how they're doing with their medicine?
Yeah, so the side effect profile can be very important with these medications. And one of the problems I think, that we have to communicate to our patients is that we're not putting them on medications for fun. We're putting them on medications because in many situations we're really talking about life-saving or life-extending. And so we want to be able to make sure that somebody doesn't stop their medication for a side effect that's manageable. And I think most physicians are familiar with some of the side effect profiles with the drugs, but kind of going in order of severity, the endothelin receptor antagonists seem to be fairly well tolerated. Most patients won't complain of headaches or nausea or other types of problems. And I think the biggest problems they get are some peripheral edema and some nasal congestion. And, of course, one of the problems with the peripheral edema is that frequently that will be interpreted either by the patient or the physician as them actually getting worse in response to therapy, when in fact the medication may be helping their pulmonary hypertension, and we just need to do a better job of managing the peripheral edema either with salt and water restriction or with diuretics. I'm not sure if you run into this problem, Bob, but, one of the problems I have with giving diuretics to my patients, even at low doses, that many of them are told by somebody else outside of the office that they need to make sure that they're well hydrated when they're on a diuretic. So we get a lot of patients coming back in with actually more fluid retention despite going on the diuretic. So it takes a little communication about going through their diets and salt avoidance and trying to limit fluid intake to just enough to quench thirst. The next group, the phosphodiesterase inhibitors, we tend to get, I think, a little more in the way of side effects, and they usually tend to be headaches, and a lot of people have difficulty with esophageal reflux, and some will even get muscle pain. In the majority of those cases, again, that's fairly well managed. Usually there's some tolerability, so as they start at a lower dose and kind of work up to the full doses of the phosphodiesterases and the riociguat, some of that headache will subside. People that have reflux, we talk about reflux management with antacids or keeping the head of the bed elevated or putting the bed on bed blocks so that we can get rid of some of that stuff. And muscle pain, I think, for the most part, usually tends to go away. There is this concern about loss of vision and even loss of hearing with these drugs. It's very difficult to tell if they actually cause that or if it's simply a rare side effect that we see in the population of patients that are taking the medications. So we kind of talk about those particular side effects, and obviously if there are changes in visions or hearing, we have them get back to us right away, and sometimes we do have to stop those medications in that situation. Easily the hardest group, of course, are the prostacyclins. And one of the reasons for that is because we tend to titrate the prostacyclins to the highest tolerable dose, whether it's oral therapy or parenteral therapy. And so there we're literally looking for signs of headache, flushing, jaw pain, diarrhea, bone pain. And again, we try to emphasize to the patient that we're not trying to make them uncomfortable. What we're trying to do is find out what dose makes them uncomfortable and then to adjust the dose down just enough so we're under that difficult level where it's causing side effects and still have them on the maximum dose that's going to be good for their disease. So how people manage their side effects is really critical. Far too often, unfortunately, I've had cases of patients coming saying they were started on PAH medications, but they had to stop because it caused a problem. And obviously, the problem with the pulmonary hypertension is almost always worse than the side effects. So dose adjustment, dose switching, dose titrations up and down, these are things we can do to try to make the side effects better. At the end of the day, what I tell my patients is that we have to know one way or the other whether or not they can tolerate each class of drugs, because despite all the drugs we have, we're currently just limited to 3 different classes. And if they really are intolerable of one of those classes, a phosphodiesterase inhibitor or an endothelin receptor antagonist or the prostacyclins in general, it really limits what we have left to treat their pulmonary hypertension. The good news is we have several drugs within each class, and so if they really can't tolerate a particular drug, I will frequently try them on another drug in the same class if we've gone to the other classes and they haven't been able to tolerate them. And again, at the end of the day, what we'd like to make sure is that they've had a chance to be on almost all of the medications that are available, or that we've found some combination of medications that have been able to make their disease better.
Jim, that's really helpful. Let's touch on a couple other areas. One is patients often come back and say, do I need a repeat right heart catheterization? And in the guidelines and so forth, they're sort of discussed in terms of the critical nature of it for diagnosis and consideration of it during follow-up. But what are the triggers that make you go back to the Cath lab?
Yeah, so that's a great question. You know, when we started doing this, we literally routinely cath people on a regular basis. And we did it because it was the only way we had of measuring pulmonary arterial pressure. And then as more data became available, we began to learn that the pulmonary hemodynamics didn't always tell us what we needed to know about our patients in terms of prognosis and response to therapy. And now, with a lot of different data that are available, although I don't think still formally studied in the way that we'd like to, but looking retrospectively in some cases and prospectively in others, it's become, I think, more evident that there's a combination of a variety of features that tend to tell us people who have a good prognosis and people that have a bad prognosis. And to give you a rough idea of what we're talking about, people who are able to get to that low number functional class, and that functional class 1 or functional class 2, will have better survival going forward. And people who tend to get in a good 6-minute walk distance, usually above about 400 to 450 meters, also appear to have a survival benefit. And it's the same thing with the brain natriuretic peptide. If you can get those down below into the normal limits, these people seem to have a better outcome. And same thing with cardiac index. If we can get the resting cardiac index up above a normal baseline value of 2.5 to 3, overall they seem to do well. What we don't know is we don't know whether or not those patients do well because they have the type of disease that allows them to get to those good parameters, or if indeed it's because our treatments got them there. But the general feeling is that we should do everything we can to try to get them into those favorable risks categories. And some of those things we can do without a catheterization. We can do the walk test and check their functional class and their brain natriuretic peptide level. But sometimes, as I say, it gets difficult to see where they're at because somebody's walk test may not be so good, but their BNP may be good, or vice versa. And that's when we usually go back to the catheterization lab and see whether or not the overall hemodynamics are getting better. There's a fairly recent paper that was published just this year out of France by Dr. Weatherald and Dr. Sitbon as the senior author, and they looked just at this kind of thing. Was there anything that you could find on a follow-up catheterization that told you whether or not your patient was likely to do better? And the answer was yes. There were a variety of indexes that you can look at that were associated with a better prognosis. Again, we don't know if that better prognosis is because it was achieved by the therapy we gave the patient, or if responding favorable to the therapy is what put them in a classification of better overall survival. But it certainly helps, I think, doctor and patient get an idea of where they're at and where they're going.
That's terrific, Jim. Let's just touch on one concept in patient care, which is how we coordinate with the patient's local providers if they're coming some distance to our centers. And of course, through the Pulmonary Hypertension Association, we now have the comprehensive care centers, which are really able to supply terrific expertise in terms of pulmonary arterial hypertension and potential for consideration for lung transplant and things of this type, and also the pulmonary hypertension care centers that are recognized as centers that have expertise in pulmonary hypertension, but are not quite as broad in their depth and range of possible approaches that a comprehensive care center would have. Can you talk a little bit about this issue of, well, the patient doesn't really want to come back some distance to the center as frequently, and how you would share care with the local providers?
Sure. So, I think this is really a key that's been emphasized more lately as we've gotten into this area of multiple therapies and multiple types of pulmonary hypertension. So as we all know, patients that have pulmonary arterial hypertension are very rare indeed. I think the estimated incidence is someplace between 1 out of 500,000 to 1 million patients per year, and the prevalence is only about 1 per 100,000. So for the average practitioner, it gets to be very difficult to develop experience with multiple types of pulmonary hypertension. So it's very beneficial in this day and age to have a PH center where you can call and get some advice. And I think it's relatively easy, particularly by telephone or email or different types of electronic medical records now, to share patients' response to how they're doing. And so if you have a readily available resource in terms of a PH center where you can say, hey, I saw my patient follow up today, and so far his walk test is a little better, but he doesn't feel much better, and his BNP is a little higher, and we got a repeat echo, and it shows this, that, or the other thing. It can be very helpful to get some input as to whether or not it's time to go up on the dose of a medicine or add a second medicine, or these issues we were talking about of when to repeat the right heart catheterization. These all are things that you can get a lot of help from by having an area where you can get input from. Sometimes, over the telephone or on the computer doesn't do it, and so the referring center, or I should say the expert center, wants to see the patient. But again, that decision can be made over the telephone. And I think patients are usually, fairly receptive to this. That is to say, if their primary care physician or their primary pulmonologist and cardiologist is working in conjunction with another expert, and they say, hey, look, we did your studies and we discussed it on the phone, and they'd like you to come up and see them for an extra visit, this year or this half year, I think most patients are receptive to that idea. And then, of course, the back and forth between the center and the providing physician can make the patient feel better and the primary provider feel better as well.
That's really helpful, Jim. And it really can work very nicely if there can be that good communication and collaboration in this regard. And I think it sort of reduces the intrusiveness of dealing with pulmonary arterial hypertension, may reduce the cost in terms of days off of work and days traveling, and generally can improve the overall quality of life that people with PAH have to deal with in terms of their frequency of contact with the medical system. But it takes work, and it takes both a PH center and the more local providers to be willing and engaged and able to communicate effectively. But the more that I do this, the more I'm convinced that it can be a very good way to take care of patients and really can optimize their experience with their condition.
Yeah, I think it depends a lot on where the patients are, too. It's kind of interesting. So here in New England, we have, I think, 6 PH centers that are within 35 miles of each other or some ridiculous thing like that.
That's amazing.
And it's very common for patients to go to multiple centers to seek, second opinions and whatnot. And it's also very common for primary care physicians to refer their patients to a PH center right away because in many cases it's just around the corner or just down the freeway. But coming from a place where you are, Bob, where the Mayo Clinic literally developed itself as a referral center where people came from hundreds of miles away, it's probably an entirely different situation. I'm sure you've got people out in the Dakotas and other places where to come to see you on a regular basis would be a real inconvenience.
It's exactly right. And sometimes have one of these spring blizzards that come across, and all the patients from North Dakota can't get here, or they battle the snowdrifts to get here, and so that coordination of care can be really valuable. Well, Jim, it's been great to chat about these issues of follow-up, and I think this has been very helpful. And thanks so much for taking the time today. I appreciate it.
My pleasure, Bob. Thanks again.